Health CRP Strategy. Health is one of the most serious casualties of poverty, social exclusion, marginalization, and lack of sustainable development in most villages. The health problems facing the villages are rooted in this context, as are the potential health benefits of a broad human development strategy. Securing health system is critical to combating major diseases. For disease prevention and control programs to be effective, appropriate interventions must be made available and accessible to the people in need in a timely manner. All healthcare programs need functional and effective health systems which provide prompt and appropriate responses to the health needs of the population. Success of such programs, in turn, strengthen the health systems and services as well as build confidence in the users. Central to any effective health system is sufficient numbers of capable and committed health workers, particularly so in more remote areas. Poverty and ill health are part of a vicious circle in which poverty undermines health, and ill health is often a root cause for poverty and a reason why individuals are sometimes unable to escape from the poverty trap. There is much that individuals and families can do to improve their own health. For example, a drop of chlorine in a liter of water can prevent diarrhea, while the early use of homemade oral rehydration solution can prevent death from dehydration. Use of insecticide-impregnated materials helps prevent malaria. Seeking healthcare early for children with fast breathing, a cough and a hot body would reduce deaths from pneumonia. Lifestyle changes in diet and exercise could impact positively on health and life expectancy. There is a need to empower individuals and communities to take action to improve their own health in a manner that enhances dignity and provides information to support decision-making. Health services need to be supplemented by efforts of communities and social structures. These efforts are diverse in nature, ranging from campaigns to care. They have the ability to achieve results and mobilize energy and volunteerism in a manner that is difficult for formal health services to match. Health literacy means attaining the basic knowledge and skills to enhance a person's health in a manner that favorably influences attitudes and behaviors. Achieving health literacy allows people to experience the benefits of better health. Women become members of a group on equal terms and use their resources towards common goals. Who are health community resource persons? A group of trained people which mobilizes the community, assesses and analyzes community health problems, builds awareness among people on key health issues, prepares a health and nutrition plan for the village, lends support to SHG members in the execution of the plan, monitors and evaluates progress on participatory lines. Selection of Health CRP members. A good CRP should be identified and recommended by her own village organization to be trained as a Health CRP. She should be willing to travel 15 days in a month to villages in other districts and also other villages in her own district and work in her own village for 15 days to promote health interventions as well as to help members in other communities. And to do this, it is essential to have her as well as her family's consent. The criteria for selection of a Health CRP is done on the basis of the experience she has had in the following. The member selected should be part of a SHG group. The member should have requisite working experience in any of the 45 health and nutrition pilot mandals. The member should be a best practitioner of health savings, food security, trainings in prevention of ill health and promotion of health care. The member should have had orientation and exposure at CRHP Jamkhed. The member should have introduced health as an agenda in the SHG meetings. The member should have had the requisite experience of setting up a nutrition center in her village. The member should have initiated activities related to water sanitation involving the youth and the panchayat. The member should have organized nutrition and health days. SERP, the Apex Institute, set up by the government of Andhra Pradesh for the purpose of implementation of poverty reduction programs in the state, coordinates the entire ongoing activities. With the help of field coordinators and village organizations, it identifies potential CRPs from among the active SHG members who are either health activists or health subcommittee members. To enable health CRPs to effectively implement healthcare programs that empower the poor to address their health needs requires exposure and training. The main focus of the Health CRP strategy is the knowledge and capacity building of rural women for addressing the first level of community healthcare needs at village level itself, and then to generate demand for the public health entitlements of the community. They also ensure that the services are availed by the members. At every step, training is imparted to the members by experts on various health and nutrition components. Adequate participation of government officials is also ensured. It is made sure that the information passed on to is practically implemented at the grassroots level through on-the-job training support. Module 1. The health community resource persons are trained to perform multiple tasks to make efficient use of limited resources. They recognize the multiple roles of women and also the need to offer health services that are comprehensive and holistic. The training begins with a 10-day orientation course. Say 40 women participants get trained. They are divided into 8 groups based on their individual expertise in various health and nutrition components. Intensive training is imparted in the chosen area with focus on knowledge, communication skills, and attitudinal change, which in turn helps the members influence behavioral changes at the household and community level. To begin with, the participants are provided with the necessary concept papers with a clear focus on the expected outcomes under each component. Now, the participants are trained in various techniques in order to facilitate the members in the community to help realize the effectiveness of the said component. Each CRP is expected to practice and demonstrate it to the entire group in the training program. Based on the demonstration she gives, the CRP is assessed under 4 areas, that is, knowledge, communication skills, clarity on outcomes expected, and conviction in the said component. If any lacuna is observed, the CRP further undergoes training by her co-members. Once the training in the first module is completed, the 40 members are formed into 8 teams with 5 members each per team. All the teams have experts in each healthcare component, that is, health agenda, health savings, nutrition center and food security, trainings, water sanitation, and NH days. The District Project Management Unit identifies the villages with the following prerequisites. The village is covered by Institution Building CRPs, IB CRPs, The village organization has constituted 5-member health subcommittee and has also positioned a health activist. Health savings as well as food security measures are initiated. In the pilot mandal selected, the DPMO should have positioned HNCC, master trainers and a district anchor person. The trained CRP teams leave for the villages allotted to them with fresh enthusiasm and understanding of the principles of community-based primary health care. Here, they gain field experience before they go to other districts to roll out the Health CRP strategy. These teams are now called external CRPs. They are assigned districts to roll out the Health CRP strategy. Over a 2-month period, they stay for 30 days in one village to implement the strategy. This way, in a period of 6 months, 5 external CRP teams allotted cover 15 villages per mandal. These CRPs who are assigned a said district do not belong to the district they come from. Module 2. The Health CRP strategy is conducted in 7 phases. Phase 1. For 15 days in the first month. It begins with a survey by the CRPs to identify the status of the healthcare components prevailing in the villages and share the details of findings at the Gram Sabha that involves the village organization members, the panchayat and functionaries of line departments such as ICDS, Health and Rural Development Department. For successful activities, it is always helpful to first plan them carefully and put them in order of priority. The CRPs explain to them their plan of action regarding their 30 days stay in the village over the next 2 months and obtain their consent to take 5 village health subcommittee members and health activists in order to provide hands-on training to them during the period. 6 months hence, these trained health subcommittee members, health activists and any other SHG member interested in the activity become the internal CRPs, who in turn reach out to other villages to roll out the healthcare strategy in the area. After the first 15 days stay in the villages, the external CRPs return back to their respective villages and work on all the healthcare components in their own village. Phase 2 for 15 days. During this period, action for implementation of all the health and nutrition components is undertaken in the villages assigned. At the end of the 15-day period, the external CRPs leave the village after conducting a Grama Sabha. Here, they hand over the responsibilities to the internal CRPs, Varasulu 1 and 2, so that they continue doing the good work. They take time to be encouraged by progress, however small. This is a process that facilitates the CRPs and the community to work together for efficient service delivery. The process of learning and working together gives the community value addition. Phase 3 for 5 days. In this phase, Varasulu 1 and 2 along with the village youth members and the Sarpanch are sent to CRHP Jamkhed for orientation and exposure. Here, on-site training in community-based primary health care for community-level workers is provided to improve health in poor communities served by participating organizations. Phase 4 for 2 to 3 days for evaluation. After 2 months, the external CRP team visits the same village to assess the effective functioning of the healthcare components. In case any lacunae are noticed, they lend support and help bridge the gaps. Phase 5. After 6 months, after implementation of the healthcare activities in their area, the trained CRPs, Varasulu 1 and 2, will now be identified as internal CRPs. Phase 6. The internal CRPs graduate to the position of external CRPs. Once the 5 phases are successfully completed, the internal CRPs identified from the villages covered by the external CRP teams are imparted further training by the SPMU, State Project Management Unit, on all the components covering the Health CRP Strategy for about 3 to 4 days. After this, they are tagged on to the team guides to go over to the other districts attached to them in order to get intensive hands-on training in the field. This is considered probation period that lasts for 4 months, that is, 2 rounds in 2 villages. After completion of their probation, the internal CRPs graduate to the position of external CRPs, now capable of handling all the healthcare activities independently. Phase 7. Debriefing sessions. However much a team has managed to achieve, there will always be many more things that can be done. The SPMU team, along with all the health CRPs, conducts a debriefing session once in 2 months to look back at what has been achieved, studies the group's records, decides what have been the strengths and weaknesses, looks at how things could have been done more effectively, and then makes new action plan for the next village. Debriefing sessions are also conducted to assess the performance of the health CRPs, first in their own village and then in the villages allotted to them in other districts. A team that used the ideas suggested for planning will find it much easier to evaluate their work. The health CRPs, through the successful implementation of healthcare activities, are required to make their own village as a model in a period of 6 months. The same needs to be accomplished in other assigned villages within 2 months. The debriefing sessions are attended by Dr. Arole from Jamkhed and the line department's unit heads like secretaries, directors and SCRP officials. The training contents and information on various health-related issues are reached to the target communities through a wide range of training materials such as flip books, training films, tools to track the outreach of health services training material on child health, women's health, first-level curative care of primary ailments, Health and Human Development Index based on rural health planning, food and social security schemes, herbal remedies, neonatal and child survival measures, etc. The Health CRP strategy began with training 40 SHG members. The numbers gradually rose to 700 in 18 months period. As trained CRPs come out once in 6 months, new CRPs in 250 to 300 numbers will be identified and trained every 2 months. This will eventually increase to 1,500 trained CRPs in a period of 12 months. The scale-up of health CRPs is possible only through intensive training on a regular basis. The uniqueness of this large-scale program lies in the fact that it lays stress on continuous training, support and organization of rural, sometimes even uneducated, ordinary women to work for the healthcare needs of their remotest localities. There are series of training programs existent from the state level up to the village level through whom the messages are communicated and continuous interactions follow. The knowledge level as well as social confidence of the health CRPs are built in such a way that they are in a position to impart knowledge to other members of the community, especially women. The Health CRP initiative is designed to transform the health sector so as to address the health needs of the entire population with special emphasis on reaching the poor and the marginalized. That this strategy is a transition from the existing structure of health services to community-based health services.